We have the strong opinion that hormones are so beneficial for the brain, but there's always this complexity of, do we start hormones in senior women long after they've gone through the complexities of menopause? And so that's my focus today. And I've had a lot of the reason this is coming up today is that this week I have consulted with executive directors in assisted living centers. I've spoken with a consulting pharmacist to assisted living centers that are calling on assisted living centers with dementia care units or memory care units. I've had a conversation with a family practice doctor from one of our clients who's trying to stave off the ravages of dementia. And I had a conversation with a young lady who is taking care of her mother. Her mother lives in her home and she's hesitant about hormones because she's heard all of the naughty details. And so I thought, okay, this has surfaced enough this week. I've got to address this one issue. Not just are hormones helpful, but can we start them in a 75-year-old woman? Can we start them in an 85-year-old woman, even though they went through menopause 40 years ago? That's the topic of today's discussion. And I'm anticipating sharing this with an audience that's broad. So if you take care of a family member or a loved one that has dementia and they're older, you've got to understand this. I want family practice doctors to get a copy of my lecture today because I think it will help distill some of the fears that they have. Executive directors in assisted living centers need to hear it. Directors of nursing need to hear it. And anyone who wants to avoid the ravages of Alzheimer's, maybe you're listening to this because your memory is not as good as it used to be, and your doctor has not given you any hope that you can make a difference. Okay? So there's my anticipated audience. Our group needs to understand that worldwide, women get Alzheimer's dementia twice as often as men. That is not fair. Alzheimer's is a sexist disease. It affects more women than men. And that's a problem. And so many people have tried to figure out, what is it? Is this in the chromosomes? Is this in your genetics? And overwhelmingly, the prevailing thought is growing. It's because women go through menopause and men don't. Women have this definitive time in their lives when the ovaries shut down. And men do not have a definitive time in their life when their testes shut down. Most women wish that they did because they keep being frisky into their 80s, right? They want some snuggling and some loving late into their 80s. And the women are like, oh my gosh, give me a freaking break. And it's because women, your ovaries shut down. We think that's one of the drivers of why Alzheimer's disease affects women 2-to-1. So we have to address this, okay? And so this question always arises. Can we treat neurodegenerative disease, or is it hereditary? And the next question is, can we slow it down? Once you have a diagnosis, can you slow this down or stop the progression? Because we all know where it ends. So for Pete's sake, let's slow this sucker down. And the third one is, when is it too late to actually do something about it? I get this all the time. I get calls that say, I got a call from a guy in California this week that says, my mom's living at home. She doesn't live independently. We pay a caregiver to go in all the time. Is there anything I can do to slow this train down? And so my thought is, well, listen, hormone therapy is probably a part of the process of slowing it down. And so then the question is, well, when is it too late to even consider hormone therapy? And I'm going to say up front, never. It is never too late to embrace this, period. I don't care if you're 90, and I'm going to give you the rationale today as to why I've developed that opinion, okay? So there's this weird chasm or gap between what's in academic medicine. Academic medicine is what's printed in the research. And then there's this gap between what is the standard of care. I tell you right now that I read a lot and I can't keep up with the research. There's 5,000 articles printed every day. So how can you possibly keep up? So the standard of care that I'm practicing now is likely different than what's being printed in the research journals because we can't keep up. And everywhere there's functional medicine doctors. Many of you have naturopaths on your team. You take prescription medicines. Maybe you see a chiropractor and a massage therapist. Some of you take supplements. Some of you have really embraced lifestyle. These things have to merge at some point. There's no one group of academia that has all of it. So we have to figure out how to merge these together. And I feel like we stand on the shoulders of giants. So I want to make an effort to give credit where credit is due. So a lot of people say, well, Randy, where do I go to school to learn what you do or to practice medicine like you practice? And I always chuckle because I came through the pharmaceutical round, and the pharmaceutical school that I was in, that was 20 plus years ago, right? And then you have experts all across the country who practice this form of functional, regional, combined medicine. And they've written New York Times bestsellers. They lecture at all of the continuing ed, but you have to be dialed into it. It's so interesting. I was watching a group of people talk about research, and I asked them, where did you get the research? And they said, well, I saw this on TikTok. And I saw this on my Instagram account. And I thought, okay, that doesn't mean it's bad, but it certainly doesn't mean it's right either. You've got to figure out, where is this data coming from? And so I always try to reference where I'm learning. I don't create anything on my own. I'm not original, right? I'm the ultimate copycat. I'm going out taking the research from the best and just trying to aggregate it for people like you who want to do the right thing. And so there's this weird elephant in the room, and the elephant is considered hormone replacement therapy. What in the world do we do with estrogen, progesterone, and testosterone? And for the purpose of this lecture today, what do we do with those hormones in 75-year-old women? And you can work backwards. I think the argument gets easier if you're 65, and it's even way easier if you're 55. And this is an absolute no-brainer if you had a total hysterectomy in your 40s, because you go through surgical menopause instantly. But it becomes more of an issue through the aging process. And ask yourself this question, ladies who are listening: when did you stop being female? Did you stop being female when you went through menopause? Or did you stop being female at 55 or 65 or when you had a total hysterectomy? You never stop being female. So we should be thoughtful about this. If I took your thyroid gland out because you had thyroid cancer, I wouldn't say, well, you're too old to replace your thyroid. That would be unethical. So we have to be thoughtful about saying you're never too old also to optimize your female hormones. Okay? And so here's the question. Can hormone replacement therapy be given to women who are seniors, 70 to 80 years old, as an additional strategy to improve their brain health? Okay. And from a historical perspective, hormones are risky. They should only be used during the symptoms of menopause, and we should only use them in the lowest dose for the shortest period of time, and because they really only make a difference for reproductive and sexual health. And I'm here to tell you that I think all of those are completely bogus arguments. They're risky arguments, and they actually damage women's health. They injure women's health. So where do I come up with that? Well, in fact, there's an argument that said if women get breast cancer, what a sensitive topic. My gosh, I have to be so sensitive around this because women who get breast cancer are told never take hormones. In fact, now we should be blocking your hormones. And that perspective always comes from the perspective of cancer. We're treating cancer. We're not treating the woman. Because if we were treating the woman, we would have a little bit more respect to the power of a hormone, right? And so I'm gonna go in and keep talking through this. So there's this ever-changing perspective. Do you guys remember during the COVID pandemic, there was a war amongst doctors in our country? There seemed to be kind of an even split, almost like Democrat and Republican, right? And this argument was, well, during COVID, we should social distance, wear a mask, and get the vaccine. And other groups of doctors said, hey, I wonder if we replaced your vitamin D level and we increased your zinc level. What if you got some sunlight and you did some exercise and lower your blood sugar? Would it lower your risk? And my gosh, that argument was brutal. If you took a side, you got canceled by the other side. And I found myself ducking my head. I work for a hospital organization, and there was this argument: everyone gets the COVID vaccine or you don't get privileges of the hospital. Well, that would negatively impact my work. So I'm kind of caught in this storm, even though there's a part of me that leans natural in much of what I do. It was a very difficult time. Well, guess what, my friends? The exact same thing is the same argument that happens in hormone replacement therapy. In the 1970s through about 2001, hormones were deemed fantastic. They helped women. They optimized the aging process. Women lived longer and it prevented cardiovascular disease. That is why they even conducted the Women's Health Initiative, because they wanted more proof that women aged better and had less cardiovascular disease when we put them on Premarin, right? And then the dreaded study, Women's Health Initiative in 2001 came out. And you'll see I left a blank there from 2001 until 2000, blah. It's blurry. Why? Because there's still this concept that hormones are dangerous and risky and they cause breast cancer and blood clots, and you should use the lowest dose for the shortest period of time. And then there's a group of regional doctors budding up all across the country that, guess what? We're going back to our roots. We're saying, no, these are not the devil that we said they were for the last 20 plus blah years, right? You still find this out there everywhere you go. So this is, now I'm going to get into the evidence and the research. One of my patients this week sent me this picture. When I was talking to her about prescribing hormone replacement in her mother, she pulled this out and said, when I was a young lady at a bar, I saw this public service announcement. And this was put on by a comedy club. But I thought it was, I asked her, would you send it to me? Because I want to use it in my presentation. And she said, sure. And the final writing at the bottom of the screen, I retyped it so you could read it. And it says, I may be the only girl in my high school going through menopause, but I'm not dumb enough to drink horse urine. Premarin, which at that time was the most widely prescribed menopausal drug, was made from pregnant mare's urine. That's why it's called Premarin. And its production causes misery and death for tens of thousands of horses and their foals every year. It's one drug you're never going to find in my locker, right? This is the statement. And then the interesting thing, look at how disrespectful this. It shows her lips like she's drinking horse urine. It's such a sassy advertisement. And look, it's put out by PETA. So it's put out by an organization that wants to protect horses. Well, I don't have a grind against anyone, but it shows you how charged, politically charged and emotional this topic has been for years and years and years. Okay? So again, if we go back to the elephant in the room, what are we going to talk about? This is where I want to get into the research. This is Dr. Marty Makary. Dr. Marty Makary wrote a book called Blind Spots. Now pay attention to the subtitle. The subtitle of this book is When Medicine Gets It Wrong. And when it gets it wrong, what does it mean for our health? Now, Dr. Makary is not Randy Vaudry practicing in Southern Idaho. Dr. Makary is from Johns Hopkins University, and he's a public health researcher. He graduated from Harvard Medical School, and now he teaches at Johns Hopkins. But it gets better than this. He wrote this book a couple of years ago, and then he went on a national bestseller tour and talked about what are the blind spots in medicine. Dr. Makary was recently confirmed as the new managing director of the Food and Drug Administration. So we're not just talking about some regional Randy Vaudry out there, right? Some nurse practitioner in Southern Idaho who says, hey, you guys should reconsider your perspective on hormone replacement therapy. I'm going to give you the opinion of the director of the FDA in the United States. And he did an interview with Megyn Kelly, and he talks about this. It's about maybe 4 or 5 minutes long. I'm going to play it for you. So here we go.
Not an honest broker. So the book lays these people bare. HRT was another one.
Talks
hormone
about
replacement
HRT,
therapy for women, where everybody's getting it.
therapy.
Women loved it in their 50s and whatever. And then they said, oh, it causes cancer. You know, shouldn't do it. You're going to get breast cancer. And only recently, and we covered this on the show, did they say, that's actually not true. You might be able to take HRT with absolutely no problem. Talk to your doctor, see what your breast cancer risks are, but it's a minuscule risk to the increased
Listen to
breast
his
cancer.
response.
There's actually zero increased risk of breast cancer mortality in the original study, and no one did the investigative journalism to actually look closely at the study. And I found the guy who made the announcement 22 years ago declaring that hormone replacement during menopause causes breast cancer, and he's talking over my head and trying to talk statistics, and it was a very interesting long conversation, and he's talking to the wrong dude. I have a degree in epidemiology and biostatistics from Harvard. And so we talked the numbers, and he acknowledged to me after we stuck to the actual data that there was no statistically significant increased risk of breast cancer or breast cancer mortality.
my
Women who took estrogen alone had a 25% lower rate of breast cancer. And yet 50 million women have been denied this amazing therapy that helps them live longer and feel better because of this dogma put out by this one doctor from the NIH who hoodwinked many of his co-investigators in a meeting just before his press conference where he said, hey, we're going to do this. I'm going to make this announcement. And I find out there's a shouting match that happened in that meeting in 2002. They said, you can't put this out there. It's not statistically significant. And if you scare women with fear of breast cancer, with something as sensitive as breast cancer, you will never be able to put that genie back in the bottle.
And that was really true.
80% of doctors today still will not prescribe hormone therapy or try to minimize the amount of prescribing because they will tell you that it causes breast cancer. And when you ask them why, they will point to the 2002 Women's Health Initiative that was announced by this doctor without releasing his data until later after the media ran with the headlines. And just for context, Megan, arguably with the exception of antibiotics, there is no medication that improves the health of a population more than hormone replacement therapy for menopausal women taking estrogen or estrogen. They live on average 3.5 years longer in the group that took it. Their nitric oxide levels are higher because the estradiol oxidizes. So their blood vessels are a little softer, more dilated, more healthy, improves the blood flow. It's also believed to help with nerve conduction. That's why it may be that many researchers have observed 50 to 60% less cognitive decline in women who start hormone therapy.
And on top of it, it helps you sleep better, and greater sleep is better to prevent Alzheimer's and all those things.
Yeah, 35% lower risk of Alzheimer's in one of the big studies. The short-term symptoms of menopause that last, say, 5 to 8 years are either eliminated or alleviated in part from, so there's less suffering, less mood swings, less weight gain, less
bone breakage later.
Brain, a 30% lower rate of breaking a bone, 50% in some studies. So if a woman falls later in life, they're far less likely to need surgery or have a broken bone. My mom just broke her hand and just about a year ago. She's fine now, but she was never given hormone therapy. The fracture was borderline if it needed surgery, but the colleagues I trust at Hopkins said, she should really have surgery. Had this guy never made this false claim, misrepresented his data, I got to wonder, could my mother have avoided all the immobility and cascade of events?
That's amazing.
So women feel better, live longer.
Not to mention, we had a doctor on the show, not this past summer, but 23, who was saying it can help with sex drive because as your estrogen goes down, and if you get it just back to normal, for women, it can, I don't want to say it's a miracle drug, but it's kind of a miracle cocktail.
It's pretty amazing. Less dryness is true, and a 50% lower rate of heart attacks in one study because the blood vessels may be healthier.
That's incredible.
And to this day, this NIH scientist created this dogma that resulted in one of the greatest screw-ups of modern medicine. And it's still going on. That's why I wanted people to know about this, and that's why I write about it in the book.
Can you speak about the microbiome?
All right. Isn't that interesting? One of the greatest screw-ups in modern medicine that's negatively affected the health of over 50 million women for the last 25 years. It's unconscionable. Again, that's not my opinion. That's now the acting director of the Food and Drug Administration. So let's just quickly review what he says. 0 increased risk of breast cancer mortality in the original National Institutes of Health study. It was a misinterpretation. It was a personal grind of one of the doctors that made that announcement. And in fact, women who take estrogen alone had a 25% lower rate of breast cancer over time. That's the complete opposite of what we're told in medicine. 50 million women have been denied the benefits because one doctor had this opinion. And today, 80% of doctors will not prescribe hormone replacement therapy because of that perception that exists from that study. I run across this every day of my life. Eric and I do consulting in assisted living centers and nursing homes. And all the time we do case reviews and we say, well, you want to consider hormone replacement therapy? And the response is, no way, too risky. We're not doing it. And then they turn around and prescribe an antipsychotic medicine that's used in schizophrenia as a first-line treatment. Now, I'm one that recognizes we may actually need to get there with certain individuals because when dementia is progressive, we got to have some tools, but we never start there. That's a problem to start there. He goes on to say that with the exception of antibiotics, there is no medication that improves the health of a population, meaning women, more than hormone replacement therapy. My gosh, that is a powerful statement. It expands longevity by 3.5 years. It improves nitric oxide levels. You guys have probably seen some of the research that says men who take Viagra on a regular basis have lower rates of dementia. That's why. It's because nitric oxide helps brain function, right? You get better blood flow when nitric oxide is elevated. 50 to 60% less cognitive decline in women who start hormone replacement therapy, and 35% less Alzheimer's disease, let alone women. You sleep better with a little bit of HRT, and women experience less depression, less mood swings, right, with HRT. He goes on to finish and think of this, 30 to 50% less osteoporosis. There's a general rule in medicine that if an aging woman breaks their hip, their risk of death is equivalent to their age in 1 year. So if I'm a 65-year-old woman and I fall and break my hip, there's a 65% chance I'll die before the end of the year from the complications of that hip fracture. That's horrible. Hormone replacement can optimize that. Less vaginal dryness. When I hear women say, God, I keep getting urinary tract infections, we have to be ambitious with estrogen. That helps change vaginal dryness and women do better. Improved libido and increased comfort with intimacy, and a 50% lower rate of heart attacks. There isn't a drug on the market that lowers the risk of heart attacks like hormone replacement therapy in menopausal women. Okay, let's move on to a different doctor. You might recognize this guy. His name is Del Bredesen. He's the author of the RECODE protocol, and he wrote the book, The End of Alzheimer's Disease. He's a neurologist, and he has an entire program for reversing cognitive impairment. I've been trained by Dr. Bredesen in 2017. I took a picture with him. He's one of my heroes. I love him. And Dr. Bredesen recently interviewed on his membership site Dr. Gordon, who does hormone replacement therapy. And I want you to hear how she talks about this. So let me play this quick video.
Says, when it comes to bioidentical hormone replacement, is it best to take oral progesterone, or is it as effective as a topical cream? So the good news, we have a BHRT expert here with us, Dr. Gordon. Dr. Gordon, can you weigh in on this?
I would say they are all the different ways of taking bioidentical progesterone can all be good for the patient, but it depends on the patient. So if somebody's having trouble with sleep, oral progesterone in its metabolites after it passes through the liver is a much more sedating form of progesterone than the topical forms. And by topical, there's two areas where I do it topically, either a transdermal progesterone cream, and that is, convenient to the patient, they dose it themselves, or a vaginal progesterone, and that's particularly suitable if people have a dysphoric reaction to progesterone. So I learned about this from Dr. Hathaway, because in my first 5 years or so of doing hormones, people just thought they died and gone to heaven when they had estrogen and progesterone. But there really are some people who have a dysphoric reaction. And for them, the vaginal progesterone may be the best, or for people who have fibroids or excessive bleeding, you can best administer the dose to the uterus by having it vaginally. And I will say the only time I would recommend, and I think I have one patient I finally talked her out of having it removed, the only time I would okay a non-bioidentical progesterone is when bleeding or fibroids are a significant challenge to the patient and they have a low progestin IUD. It doesn't have the systemic side effects of the old-fashioned Provera, but it's not recommended. There's so many great options in bioidentical progesterone, and you just have to be flexible with the patient. Do they want to sleep? Do they tend to get depressed, need some help, extra bleeding? No, they love to rub things on their skin. Great. That'll help you choose which one you want to use.
Yeah, great.
Okay, so let's cover what she said. I'm going to dissect it a little bit. We talk about hormone replacement therapy, and then we add this word in front of it called bioidentical. Okay, so sometimes you'll see HRT, hormone replacement therapy, and sometimes you'll see BHRT, and the B stands for bioidentical hormone replacement therapy. All bioidentical means is it's not Premarin, it's not pregnant mare urine, it is biologically identical to the estrogen your ovaries made when you were cycling, right? And so, but some people think, well, bioidentical means it's just a cream or it's just a pellet. No, bioidenticals can be taken orally, they can be injected, they can come in pellet form, they can be a cream. So they come in many different forms that are all bioidentical. Well, we know that bioidentical oral progesterone is sedating. Well, that sounds pretty fantastic to me, right? Imagine sleeping great without sleeping medicine. Well, that's a bonus. How about imagine lower levels of anxiety because progesterone is very active neurologically to GABA receptors. And it doesn't matter if this is oral or topical. My wife happens to be one who doesn't like oral progesterone. It's actually very sedating for her. And if she gets up in the night to go to the bathroom, she feels drunk. She feels wobbly. She feels unstable. So she doesn't love it. Man, I've had other women that say, this is the best thing I have ever done. So you have to recognize that some women do well with oral, others don't. My wife does phenomenal with topical progesterone. It's like they're not even the same medicine because when you take it orally, one goes through the liver and the active metabolites have a different response than when you take it topically. This is important for our administrators and executive directors and directors of nursing to know about hormones, that what a great way to help our seniors sleep better at night, especially if they start sundowning, right? Great way we can rub it on their skin or give them oral progesterone. I've used this in men a lot. Progesterone is no more a female hormone than testosterone is a male hormone. Both of our bodies make it, we need it all across the board. So there's an opportunity to do the same thing in men. Topical progesterone is used if clients get too tired with the oral. And also we use it if there's a little bit of breakthrough bleeding. Remember, estrogen kind of builds up the lining of the uterus. So some women who are on hormone replacement therapy after menopause will start spotting. Well, that doesn't mean they have cancer. That doesn't mean it's dangerous. It just means that it's doing its job. It stimulates the uterus, and we need to take that into consideration in our prescribing and use of the medicine. Now, this is the part she talks about dosing it in seniors. I want you to hear how she addresses prescribing it in an 80-year-old or a 90-year-old. Here we go.
But I do see some people who have seemingly done very well through menopausal years without hormone replacement therapy, but that doesn't stop me from trying to get them on it when I do meet them, or at least using phyto hormone, using genistein or something like that. But I haven't seen that. I'm sort of you should only use them if you want to look better, feel better, and live longer. So
Yeah,
I don't see any
those
reason
who
not
don't
to
want that. Yeah, we hear so much now about anti-aging. This is everywhere, and we want to do the same thing for the brain. So, all right, this is very helpful. And people who, the common thing we get almost every week, we have a question from someone who says, okay, I'm trying to be treated for my cognitive decline, but I'm in my 70s. Surely you would never give me BHRT. And then we have the experts who are saying, no, but it actually is helping your cognition at every age. So what do you tell your patients who come in and say, I'm now 15 or 20 years from menopause. Are you really going to give me BHRT for my cognitive health?
Well, the oldest woman I've put on BHRT was 87 years old, and she lived another 5 years and was a happy camper for that whole time on her BHRT. I have no hesitation with age, and to their credit, the North American Menopause Society, just at the end of last year, came out with a statement that said, particularly when there is a medical indication, and they chimed in primarily on osteoporosis, but of course we would chime in on cognitive health as well. There's no age limit as to when you can start it safely if the patient is safe for every other reason but their birthday. So if somebody's able to be compliant and take the medication and not drink alcohol excessively, or something else you might not want them to do, there's no reason not to give them BHRT. Some of the health benefits that are associated with BHRT that are of less value when you start it late, cardiovascular disease. It's definitely better if you start BHRT in the peri or early menopausal years. But it's not that it hurts you later on. It's just that it doesn't help you as much. And then with your brain and your bones, it helps at any age.
Yeah, fantastic. Okay, thank you.
But I
Randy, you're muted and we can't hear you.
Oh, so sorry. We only use bioidentical hormone replacement therapy for those who do better, who want to do better, feel better, and live longer. Well, that makes perfect sense. The North American Menopause Society just released a statement last year that says there's no age limit to when you can start hormone replacement therapy. That's an agreement between the client and the provider. There's nothing, no one's limiting that. You guys get to decide what medicines you take at all ages of your life. We know that it helps with osteoporosis at any age. We've come out with all these drugs to help with osteoporosis, right? Fosamax, alendrolate, you've heard of all of them. They pale in comparison to hormone replacement therapy, okay? And neurological benefit, the mental health, the sleep, the vitality, benefit at any age. It doesn't matter if you take it when you're 80s or when you're 60s. And from a cardiovascular standpoint, in the words of Dr. Gordon, it's not that it hurts you if you start hormone replacement therapy later in age, but it may not be as helpful as it could have been had you started it earlier about the time that you were going through menopause. Well, I did a consult just today with an individual who went through menopause because of surgery in their 40s, and they took hormone replacement for 10 years. Good on you. I love it. That's perfect. And then they stopped for a while. Well, that's okay. Go back to it. There's no risk in doing that. You may not have as much benefit had you been able to stay on that medicine your entire life. So look at this. Postmenopausal hormone therapy for cardiovascular health.
If there's one thing every woman
let me stop this real quick.
Can look forward to,
is that Dr. Felice Gersh is a director of a integrative medicine clinic in California. She printed an article about hormone replacement therapy and cardiovascular health and talked about how many women start gaining weight and they don't feel very good as they age. Well, hormones can make a difference in managing that. And she talks about this, and I love this. This comes from her study. See, we've cheapened hormone replacement and said it's really just for menopausal symptoms and just for reproductive or sexual health. And she goes on to say, no, that's not true. It's good for your brain. It's good for your heart and your bones and your liver and your mitochondria and your GI tract and your joints and your muscle and your skin and your uterus and bladder and vasculature. It makes a difference in all of these things. I want you just to hear a little bit of her statement about hormone replacement therapy.
Look back on, it's menopause. It means the stop of the periods. But that is such a tiny aspect of what menopause really is for a woman. It's the end of the normal functioning of her ovaries. The ovaries are critical endocrine organs. They make estrogen, testosterone, and progesterone. And what happens in menopause is that estrogen and progesterone, their production goes down and eventually completely stops. But when the ovaries stop making estrogen, every organ system in the body begins to suffer. So menopause is not about losing your period. It's about losing your estrogen, the most amazing hormone in charge of all of the functions of a female body. What happens after menopause? All the diseases associated with aging begin to increase in incidence, like hypertension and heart disease, diabetes, arthritis, autoimmune disease, cancers, breast cancer, colon cancer. All of these things become much higher in their incidence after menopause. That's not a coincidence. It's because estrogen is the master of the immune system, of the metabolism of the body. So what can we do? Because this is inevitable. Every woman is going to have to go through this process. The good news is that one thing we can do is we can give estrogen back. We can't make it exactly the same, but we can at least help. Estrogen is neuroprotective. Estrogen is cardioprotective. So we can give that back. In addition, we can do lifestyle measures that can have tremendous benefits for women, helping them to live in accordance with their circadian rhythms, helping them to go to bed at the right time, eat the proper diet, and take appropriate supplementation with different types of nutrients and herbals that can really help to maintain these vital functions of the body, even when the estrogen levels decline.
Isn't that an amazing statement? How many of you listening knew that estrogen impacted your immune system? It's neurologically protective. It's cardiovascular protective. It actually changes the microbiome in your GI tract, right? These are things that have been lost in the current era of talking about all the risks of hormones. This is a paper that I have relied on for 10 years. I've shared it with hundreds of doctors, and it's the potential role of estrogen in the pathobiology and the prevention of Alzheimer's disease, right? My gosh, every single woman at risk for neurodegenerative disease or for Alzheimer's disease needs to have someone that talks them through the benefits of hormone replacement therapy. So this last week, I launched a white paper. And this white paper talks about the role of hormone replacement therapy to manage dementia. It's not just prevent, but this was written for executive directors of nursing homes and assisted living centers to say, hey, look, the current model of care when someone gets dementia is we only manage it. No one really treats it. And how do we manage it? Well, we put someone in a community behind a locked door because now they're at risk of moving on. They get confused and they walk down the street and get lost. That's a tragedy. We try to keep them busy in activity programs. There's no minimization of that. I love that. But it doesn't treat dementia. It just kind of keeps them busy while they're declining. And we have excellent caregivers. I am so grateful for the CNAs and the caregivers who work in memory care centers because that is a tough job, working with people who grow anxious and irritable and ornery, and they don't want you to help them eat or change their clothes or change their pants. It's terrible. And then we give them prescription medicines to try to manage the symptoms because there isn't good treatment. So really what we're doing generally is we're kind of calming them down. We're giving them anxiety medicines. We're kind of sedating them. There's really no treatment. And I'm here to tell you that I believe that hormone replacement therapy can act as a treatment, if you will, because at any age it's neurologically active. So when the symptoms or behaviors of dementia become severe, family members and prescribers are left with fewer treatment options. And we shift over into the use of antipsychotics or seizure medicines or sedatives. These medications are fraught with very debilitating side effects for seniors with dementia. Some of them are not reversible. So hormone therapy actually allows for a very positive treatment experience with low risk for calming that neurological issue. And the disclaimer here is it's not a proven treatment for dementia, but we have 50 years that it makes a difference. That's pretty awesome. And then I in this white paper, I've listed hot links. So the person just needs to click on that. They can watch a TED Talk by Lisa Mosconi, who runs the Neurological Institute at Cornell, talking about the impact of hormones and menopause on aging. Peter Attia and Avram Bluming, who's an oncologist, do a really nice podcast talking about the benefits of hormone replacement therapy, even in the context of a historical breast cancer. And then at the end, I've listed some of the studies, the association between menopause, hormone therapy, and neurodegenerative diseases, and what are the implications for precision medicine. And then if people want more information, they're happy to reach out to us through email. I could go on, and I'm going to actually bring it to a close, but I want you to know there's another doctor named Mark Gordon who talks about the benefits of hormone replacement therapy for individuals who have had traumatic brain injury. He offers an online fellowship that I completed in 2021. And on his website, he talks about translational medicine. Translational medicine says, hey, look, if we don't study head injuries and hormone replacement specifically, we could look at how hormones affect neurological health in other instances and translate that over what happens to individuals who've had concussion or TBI. So he talks a lot about translational medicine and its role in the treatment of head injury. He's unrepentant about the role of hormone optimization for people who have post-concussive disorder. So I want to finish by saying we've developed the enhanced protocol, which is kind of the repository for identifying risk factors that lead to neurodegenerative disease. And sometimes I think we should call it the enhanced process, because maybe every person can't do everything. Maybe it's too overwhelming. Maybe it's too difficult. Maybe they can't afford some of the things. So what do? We focus on the neurological issues. We do screening and brain testing to see how they're doing, in-depth laboratory assessment. We guide lifestyles, and then we work them through a step-by-step process to help improve their neurological health. And I'm here to tell you that one of those critical steps is trying to optimize hormone replacement therapy. And I want to end with a quick case study. I'm not going to go through the whole case study, but this is one of my favorites. Her name is Lois, and Lois has done some social media with me, so she's allowed me to talk about her case. At the time that I saw Lois, she was taking 15 supplements that she had gotten through, reading Reader's Digest or reading online articles or whatever, and she was trying to figure out which would work very best for her. And we did MOCA testing, and we did central nervous system vital signs testing. Let me show you this. With Lois, she was already taking 15 supplements. She was already eating pretty clean. So one of the things that was very novel to her was using hormone replacement therapy. In her original cognitive testing, these were her cognitive tests. Look how she scored very, very low in the first percentile, meaning that every person in her age group did better on these tests than Lois did. 3 months later in September, we repeated the test and nothing was low. And I'm here to tell you, I think the difference was hormone replacement therapy. That's an example. Here's an 84-year-old woman who comes to me already taking 15 supplements, already eating good, already trying to exercise, doing all the things that we talked about. And we fine-tuned her supplements, started hormone replacement therapy, and Lois did phenomenal, right? And that to me is the case study that I wanted to share today, because it's so beautiful that people really can make a difference.